All right, structural stress testing. So, active range of motion, we want to be in a position such that we're at the level of the lumbar spine with our eyes so we're able to see well. So, we want to also make sure that we stand in the appropriate plane as to which direction the patient's going. Now, keep in mind, we're going to want to be able to guard as well if necessary for the patient. Generally speaking, as the patient's going through active range of motion, we want to look for quality of motion, quantity of motion, willingness to go through the motion, and symptom provocation. And watch out for compensation in the lower extremities as the patient's going through motion. So you might need to block the pelvis, for example, if you're seeing hip flexion or hip extension or knee motion and hip motion as the patient's going through different active range of motion planes there. And consider possibly using repeated motions as well. So having our patient say flex 10 times forward or 10 times to the back or 10 times into extension, that is, or possibly rotation or lateral flexion. I tend to use flexion and extension the most when I'm going to use repeated motions, but having them go through about 10 times. And I'll tend to use repeated motions more so when there's a radicular component to the patient's presentation, or when the patient is more difficult to provoke the symptoms, so where the symptoms aren't as bad, essentially. And the range of motion, the active range of motion, would be just like we saw for the lower quarter screen. So the only difference here is we wouldn't be doing our overpressure, essentially, and I don't tend to do the combined motions as well. So different planes will go in: flexion, extension, lateral flexion, rotation as well. And also make determinations about more in-depth testing that needs to be done at those lower extremities. Based on the patient's presentation, that is. And I talked about most of this, or we've talked about most of this, but generally speaking, in terms of measurement, so there are a lot of different ways to measure motion or active motion, but essentially bubble goniometers or with tape measures. That being said, a very commonly used system is a quartile assessment. So if the patient's able to reach all the way to the floor, that being 100% of motion, if they're about halfway between the knees and the feet, that being about 75% of motion. If they get to the knees, that being about 50% of motion. If they get to the mid-thigh, that being about 25% of motion. And we want to take note of whether or not the patient's symptoms are reproduced. Now, one abnormality that we might see, or an aberrant pattern, that is, as we'll see described in our clinical practice guidelines, but walking the hands up. So if it hurts to return from that flexed position back to a upright position, you might see the patient, as we see in our pictures here, using their thighs to walk the hands up, that being a way to decrease loading on the spine as the upper extremities are helping out, essentially. And you can take time to read through these descriptions if you need to for different planes of motion here. That being said, we'll move on to our passive range of motion next. So this is done with our patient in sitting. There are some alternative ways of doing this. So for example, looking at flexion, we could have the patient in quadruped and then sit back on their ankles while keeping their hands on the table. So basically a double knees to chest, or a supine double knees to chest as well, potentially. Or with our extension, we could potentially have the patient keep their pelvis on the table and either come up onto their elbows or up onto their hands while they arch their back. That being said, those are alternatives, noting that those alternatives aren't true passive range of motion, but they are less aggressive than just full active range of motion. So let's take a look now at lumbar passive range of motion here. Come on, Zoom.
Bring her down. Extension, lower lumbar area. Scoop up at the same time.
So you can see the scooping motion in the TV screen in the background there if you need.
Trochanter on the contralateral side. And we're picking her up on the side that's closest to us at the same time we pick her up on the contralateral side. Rotation in the contralateral direction.
Not the best view there, sorry, especially the last one. But I figured that it was better to have that than see it with the skeleton. So hopefully that was helpful for you. And take your time to read through the procedures here for passive range of motion if you'd like, as well, this being more so for reference than anything. And also flexibility testing that you might want to do for a patient with low back pain that I know you've been over in prior classes. So Thomas test for looking at those hip flexors and Eli's test, the 90-90 or the straight leg raise test for hamstrings, not to be confused with what we looked at earlier for the straight leg raise for radicular symptoms. And our Ober's test for TFL, IT band, inflexibility. Now our resistive testing, we're going to check in flexion, extension, lateral flexion to both sides, and rotation to both sides. So let's check out the video for that.
There, don't let me push you forward. So I'm pushing at the back there. Slightly pushing at the arms as well, trying to bring her into flexion, testing extension. Hold that there, don't let me push you back. So, hand down here, trying to push her back, getting her to challenge that with flexion. Now, the bigger differences here, lateral flexion, we're going to get under the greater trochanter. Hold that there, don't let me push you to the side. So I'm going to pull up at the greater trochanter, just like we did for passive range of motion. My instruction to her is to not let me move her. Right? So hold that there, don't let me push you. I'm trying to push in this direction, so trying to push her to the right, thereby testing left lateral flexion. Hold that there, don't let me rotate you. Mostly through the scapula here, a little bit through the arm on the other side, and trying to rotate her to the right, thereby testing left rotation. Resistive testing with that. And come to the other side, test the other side, lateral flexion and rotation. Let's go. Put that there, don't let me push you forward.
All right, so that being resistive testing, give you my screen back. And again, other testing that you might see, also your manual muscle testing that you learned in clinical practice. And you can take your time to read through these instructions if you like. Really, they're more for reference. I discussed most of this with our video that you just saw.